Today is Wednesday, the 19th of June, and we're joined with Simeon Niel-Asher for the language of touch. This webinar came about because of your last webinar that you did with us, and we briefly touched upon it, didn't we? We were like, we want to know more, Simeon. So this is how this has come about.
So let's get started. First of all, it's been actually really interesting to write it's a new kind of summary of some ideas that have been going around in my head for a while. And I played with this quite a lot of the slides. So Pindi, I'll give you the slides obviously to share after, but just try and bear with me, because what we're going to cover, I think, is for me a really fundamental and fascinating idea. And we're going to look at touch. Oh dear. We're going to look at touch in different ways. We're going to look at therapeutic touch. We're going to look at the neurology of touch. We're going to explore touch in some of its kind of deeper meanings. So first of all, for those who don't know, I'm an osteopath, qualified in 1992 from the BSO. And I've been working with trigger points is a big thing for me. Now, trigger points are touch-based, although of course you can use needles as well. But for the first, I don't know, like 25 years of me treating them, I didn't put a needle in at all. And trigger points are painful. So there's a great deal of sort of therapeutic pain, which we're going to talk about. But the reason I've kind of got this ideas about touch is that after sort of many years of being an osteopath, I think touch is so powerful, therapeutic touch. I think that personally, I have a compulsion towards touching. Just to share a little bit about me, my father had Asperger's syndrome, and he actually had an inability to touch. He couldn't touch or be touched. And I think possibly it was a reaction of something that happened with me that led me to this kind of compulsion towards touch. But I think we all have a compulsion to touch. The other thing is that touch itself, I've come to believe more and more, is a language of its own. I'm sure many of you will agree. And touch does hold a kind of a magic when it's done sort of creatively and properly. So what is the language of touch? Well, I was thinking of there are really 4 Ps. The 4 Ps. It's powerful, it's pre-verbal, it's primal and primate, which we're going to look at shortly, and it's profound. Pre-verbal because when you touch the pain of someone and you connect with it, there's no need for words. There's absolutely no need for words. So clearly it is a kind of language of its own. Also, when a child falls over, or when a mum sees a child bump itself, when we see anything, we pick that child and we rub it better and we rub its bruises. So there's this complete kind of compulsion towards touch. Chat, sorry, hello. Okay, good, perfect, stay there. Right, perfect. So I believe that there's a kind of yearning or an instinct towards touch within humans, and I think that what we're going to explore today is looking even deeper at some of the ideas of the primate brain, the social brain, and where touch fits into that paradigm. And finally, I think that touch improves our sense of self. It actually touches upon something very interesting called embodiment. Now, in a world where you can be on a computer and you can be a man acting as a woman or a child acting as a grown-up, the whole sense of embodiment has changed so much. There's a fascinating book by Dr. Susie Orbach called Bodies, where she explores this notion of embodiment. And of course, for me, touch brings us back into our body. It's this kind of connection from self to self. So I think it's all these 4 Ps. And yet, what's happened with touch is that it's become outsourced in our society at the moment. It's become outsourced. Why? Because, of course, there's huge taboos around touch as well. Sexualized touch is a huge taboo. And in a sense, touch is so powerful that it's become almost too powerful. So what's happened is that certainly in medicine, there's a movement away from touch. Technology is taking us away from touch. All technology, the internet, everything is taking us away from the physical, away from touch. And yet there's this dichotomy because there's an instinct and a yearning towards touch. I know many of you will have had a career before becoming an osteopath or a healer or a touch therapist. And you hear time and time again of people that just feel so frustrated in their job with their computer, they want to put their hands on people. So there is this compulsion towards touch. And yet there's this movement in modern medicine away from touch. MRIs, X-rays, technology. Touch can't be relied upon. It can't be, it's not empirical in the sense that it's evidence-based. Your touch is different to mine. So there's a whole debate around touch itself. There are also physios now that don't believe in touching patients at all. They believe that there's no evidence for touch at all. So I think that modern medicine has sanitized touch. It's removed it. And yet we are the high priests of touch. We are the ones that are given a license to touch. So let's explore touch a little bit deeper and then see what I'm talking about. Okay. So touch is a language of its own. When I moved abroad, I couldn't speak the language well, I'm still not that brilliant, but I couldn't speak the language at all for the first 2 or 3 years, barely. And yet I was able to establish a practice and I was able to help people. And why was that? Because when you can reproduce someone's pain in the therapeutic context, when you can touch them and there's a certain reassurance, there's a pre-verbal communication that they know that you've found their pain. So in that sense, touch is a language. It is its own kind of language. It's a universal language. In fact, the mode of communication is through the hands, the medium of communication. And it's almost like words aren't necessary. When you therapeutic, especially with trigger points or painful touch, sometimes therapeutic pain that is, there's no need for speech. In fact, I came to a point where I was thinking it's something like body whispering. You've heard of horse whispering. There's a type of, for example, when you have someone sitting down and you're stroking downwards from the neck down the sort of medial border of the scapula, if you do that a few times, that you can almost sort of put them to sleep. I'm sure you've had it yourself therapeutically. There are certain techniques we use that really do kind of put patients to sleep. It's a type of there's a type of language going on there. But the other thing about touch is that in my experience with treating frozen shoulders, I use painful touch or therapeutic pain in a very deliberate algorithm. And the painful touch I'm talking about is trigger point touch. Now, trigger points are, we talked about it last time, exquisitely tender, localized nodules or nodes within taut bands of muscles. So in my work with frozen shoulders, I've been using therapeutic pain or painful touch to treat pain itself. So the idea of using nociceptive drive, nociception from the pain of touch, to change the agonist-antagonist fixator relationships. So that's another kind of part of this idea of touch. So we're going to explore that as well. And for me, working with trigger points and working with frozen shoulders for so long has kind of put all this together in what I think is an interesting, new, novel kind of way of thinking. So what we're going to do today is we're going to look at some of the neurology of touch, the kind of idea of socialization of touch, and then at the end we're going to bring it together and talk about therapeutic touch and how touch works in terms of its mechanical. I'm looking at mechanics really because, of course, there are levels of psychological, profound psychological effects of touch, but I don't think it's within the remit of this workshop to sort of discuss that. So where is touch? Well, I'd like to start by thinking about the 5 senses. I mean, of course, there are many more than 5, but really the 5 primary senses. And when we think about it, 4 of those senses are in the head. Okay. Is this okay, Pindy, by the way? Can you hear me? Are we all right? Can you all hear me? Yes. Can you hear me? Yes. Yeah. Good.
We can hear you.
Okay, perfect.
It's all good.
So, okay, perfect. Sorry. Okay, so we're going to think about 4 of those senses that are kind of locked in the cerebrum, in the head, in the skull box: eyesight, hearing, taste and smell, olfaction. And why is that important? Yeah. We'll come to fibromyalgia shortly with pleasure. So when I think about the 5th sense, which is touch, it's everywhere. It's global. The skin as an organ is massive. So you've got these 4 senses that are kind of compressed into this into this head, into the skull. And then you've got this 5th sense of touch, which is everywhere. It's global. Now, when I think about the senses themselves, I want you to bear with me a little bit to think about smoked salmon, because I love smoked salmon. But really, when we think, what is smoked salmon? It is a combination of receptors that are stimulated, of sweet, salty, bitter receptor profile, and olfaction as well, which is all stimulated. And that sends back a pattern to the brain, which interprets that stimulated pattern as smoked salmon. So really, what I want to think about now is touch in that idea as well. In that, actually, what is touch? Is this idea of bringing sensory profile, a sensory landscape, if you like, to reinforce our sense of self. So when we think about industries around the senses, we think about how the industry of hearing, we think about Mozart and Britney Spears and Taylor Swift and all of this music industry, and how this whole massive industry that formed around the sense of hearing. Smell, we think about perfume industry, this huge, vast, multi-billion-dollar industry. Taste, I mean, there are every sort of restaurant you can imagine to stimulate this kind of profile of receptors. And sight, we think of Hollywood, rods and cones that are being stimulated, and yet these images have this kind of this retinal images have these emotional qualities to them. And yet touch, when we think about the industries of touch, it's very unsophisticated in terms of compared to these other industries. So we've got, of course, massage and massage industry itself. We've got therapeutic touch industries, but actually it's relatively unsophisticated when we're comparing it to some of these other sensations. And again, the question is why? Why is that? Why is it that this global, massive kind of organ, the skin and touch, is somehow diminished in terms of its relative kind of value, if you like. So for me, I think some of these questions are answered looking at monkeys. And I want to start by, I gave a paper out that I hope some of you had a chance to look at. Was this chap called Dunbar. He's Robert Dunbar, I think. Just check, or Robin. Sorry, let me just check. His name is. So he's a professor at Oxford University. He's also done work at Cambridge University. He's been around for a long time, Robin Dunbar, and he's done a lot of work with primates, monkeys, apes. And he actually lived with ape communities twice, which were really fascinating when you read his work. And he wrote a brilliant paper, which is called "The Social Role of Touch in Humans and Primates, Behavioral Function and Neurobiological Mechanisms." How do we go back? Oh God, previous. Sorry. So he was looking at this kind of the idea of the social role of touch, and I think when I read this paper, it really threw up a lot of really fascinating concepts for me. So first of all, he talks about grooming. And he talks about the fact that grooming is just not only is it widespread throughout the animal kingdom, especially, but in primates and humans, of course, social grooming or allo grooming, grooming of other, is incredibly important in terms of its role socially in primate communities. He also looks at the idea of how touch influences relationships between individuals in those communities. It then goes into the neuropeptide basis, the sort of neurochemical or neuropharmacy of touch, and how some of these touch complexes have been measured scientifically. And he looks at the role of neuropeptides and neurochemicals and how they sort of play out in terms of touch. So to summarize, that's the wrong way. To summarize a little bit of what he said, that apes can spend up to 20% of their waking hours grooming each other, or allo grooming. Now, it's not about hygiene, because in the wild, they don't get fleas in the same way they do in the zoo when they're stuck in the same cage all the time. So it's not about picking fleas out, even though the mechanics of it are a little bit like that. And I'll talk to you about that in a second. But it's a huge investment in time and energy and food to spend 20% of your waking hour grooming. So his hypothesis and many others is, why is touch become so important, and what role has it taken on beyond that of cleanliness? Because it's one thing to sort of spend 5 minutes a day, morning and evening, brushing your teeth, but it's to spend 20% of your waking hour touching other primates. It is a huge investment. And part of what he talks about is the idea that the social brain and bonding are very much connected to touch. So now we're starting to look at the role of touch in terms of its communal role, its role of society. He said that it enhances a commitment in a relationship between two of the primates. And also it has its own neuropharmacy. So the types of touch that the primates do have different neuropharmacological effects. Grooming reduces stress and anxiety. Grooming partners tend to be consistent throughout and stable and persistent throughout time. And also there are intensely social relationships when they partner each other for grooming. So clearly, without the use of verbal language, there's another language going on in these primate communities. And he goes on to say that grooming has a social role that helps to establish and maintain, him and others, maintain social order. And of course, dominance, because these societies are very hierarchical in terms of the alpha and sort of dominance. And when he goes on to describe touch, things get really, really interesting. So what is the primate touch? Well, they have a kind of, what he talks about is a twist and a pinch. So there are two actual distinct parts of the touch. There's a twist and then there's a pinch. And he said that being groomed, and he himself has been groomed on a number of occasions as part of the tribe that he was welcomed into, the primate community. He talked about it being quite rough. There's part of it is soft and part of it's rough. And he says, the effect is not unlike that of massage. Initially mildly painful, but then gradually becomes pleasant. Okay, so I'm going to stop there. To some extent, I think, certainly my osteopathy, perhaps some of yours, unless you do only cranial, which we're going to cover as well, actually, it is something like a rough massage. What I want to think about here is this notion of, many of us, I think all of us have had a massage, and how irritating it is when that therapist is 1 millimeter away from that bit, and you just think, oh, if they were to move a millimeter to the left, oh, please do that, please. So even though it's painful, there's a kind of pleasant pain. And I think really that's what I'm talking about in terms of therapeutic pain. I'm certainly not advocating causing sort of pain for no reason at all. It's this kind of pain, pleasure, sort of interface where I call it therapeutic pain. And I think that that's part of what he's talking about when he's talking about this kind of rough massage, this initially painful, mildly painful, then gradually becomes pleasant. And of course, with this deeper touch, these deeper touch receptors, once you hold that pain for a few seconds to a few minutes, it does diminish and it starts to feel kind of pleasant. It's almost like you are holding the place and the nervous system can then manifest around it and sort of drop and let go. So the other part of the touch is the soft touch. And this arises, he says, from gentler sweeping movements, common during grooming, may activate a class of slow, unmyelinated CT afferent fibers. And these project to the, amazing, to the orbitofrontal cortex, but also through to the limbic system. So the soft touch fibers have an effect on the limbic system. Now, this is really profound because, of course, the limbic system, our primitive brain, is very much about sort of primitive sensory awareness of self and very much about our kind of vegetative functions. And emotional, the limbic, the hippocampus, of course, being the emotional center. So touch has so many levels, and when they're grooming each other, they're having so many therapeutic but social interactions. That I think that clearly, for me, this has really profound implications on our use of touch as primates, as humans. So he then goes on to explain a little bit about what he means by the CT fibers, because he talks about this separate route from normal. In fact, he says that the route is quite distinct from the more conventional somatosensory route, which is nociceptive pain, touch, heat, itch, that underpin discriminative touch. They involve sort of low threshold mechanoreceptors in the skin and fast, large diameter alpha and beta afferents. So the regular kind of discriminative touch has a different pathway to this kind of slower CT touch. And he says that the CT fibers actually project into the brain's reward centers, including the prefrontal cortex. And they give rise to a pleasant sensation of light touch when stroked. And there's some of the research there for it. So this is quite fascinating, isn't it? Because what he's showing is that the grooming itself has these different elements. It's got this kind of rough, deeper touch, and this kind of sort of softer, different. And each of these types of touch has a different kind of neuropharmacy and a different pathway in the nervous system. Oops, so I'm going the wrong way again. Excuse me. In terms of the neuropharmacy, perhaps somewhat easier to do in apes than in humans. This has been studied extensively, and he talks about two really distinctive pathways. One is through oxytocin and also through endorphins. So the oxytocin and endorphin pathways are both stimulated by touch, different types of touch. So he talks about a neuropeptide basis for social bonding, and these pathways reduce the glucocorticoid titer, which is a stress kind of milieu, oxytocin and cortisol, which we know about in terms of the pituitary gland. Also arginine vasopressin, which has been shown in pair bonding, and also these endorphins, which is very much connected to stress and well-being, anxiety, and also in terms of menstruation. So the opioids, he says, are thought to derive from fibers that arise in the arcuate nucleus of the hypothalamus. And they go from the hypothalamus to a huge range of other brain tissues, the basal ganglia, the brainstem itself, and the hypothalamus, cortical limbic regions. So the role of touch using the different pathways affects all the way from the spinal cord to the limbic system, all the way up to the prefrontal and frontal cortex, and is very much involved in bonding, in social relationships, and in intimacy. Okay, sorry. So let's start bringing this back to kind of humans a little bit. sex industry. Right, it's true. It's very true. Oh, yeah. Sorry, I kind of played with the slides a little bit. I'll give these out afterwards. I mixed them around a little bit. It's my fault. I did say to Pindy that I might do that, but I will certainly give them afterwards. Sorry. Okay. So touch is a landscape. So what do I mean by that is that for the longest of times, when you're working with therapeutic pain or painful touch, you can't just be painful with a patient because it's just not nice. So I will do just a natural thing. I'm sure you will do the same. If you're doing something painful, at the same time you'll put your hand on their shoulder and reassure them, or you'll touch them somewhere else. So in effect, what you're doing is you're giving a different profile, let's say a sensory profile. And now I want us to think about smoked salmon again, because really what I'm thinking now is that what we're doing is we're changing this sensory landscape to change our sense of self. What we're doing is we're giving their problem back to them in a different way. Sometimes I think about it in terms of speaking therapy. So for those of you that have been to speaking therapists, often what happens is you go and do the talking, and they're a mirror, they reflect it back to you. And somehow by having them go through their nervous system, it allows you to integrate it yourself. And I think to a certain extent, there's a kind of psycho body thing going on as well, which is people come to us with their pain, we reflect it back to them using our techniques, and somehow their nervous system can accept it and move on therapeutically. So touch is a landscape. Why? Because there's valleys and there's mountains and there's rift valleys, and there's all sorts of nuances to touch itself. And when we think about it, when we're touching someone, we're stimulating a very discrete set of inputs. So we've got all of these different sort of embedded receptors in the skin. We've got the Pacinian corpuscles, the Meissner corpuscles, free nerve endings. We talked about the CT afferents. So at each level of the skin, there are different receptors that are taking in these types of touch. And then they're going through the spinal cord, up to the medulla, to the midbrain, into the cortex. And at each level, they're having a different neuropharmacy. And like we said before, with the idea of bonding and social pair function, and the idea of touch in the primates, where touch itself is having all sorts of extremely powerful and profound therapeutic or profound relationships with us and our patient as well, which is why, of course, another reason why it's a taboo and why it's become expertized or sort of put to the high priests, because people are vulnerable when we're touching them. And we know, those of you that are touch priests, like me and you, know how powerful that can be when you're people are vulnerable when you have them in your touch. So we, like the other primates, we use touch also to achieve those outcomes. So touch is a landscape, and it's also a kind of a neuropeptide landscape as well. So what can we learn from the monkeys? All right, so touch is a type of communication. It's developed more because they they can't speak as we can. They're not lateralized in terms of their sort of the Broca's and Wernicke's areas of the left hemisphere. They use touch as communication, and I think we do as well. Touch can be soft and rough. Touch lowers stress and anxiety. It increases trust. It's bonding between pairs, and it also induces pharmacological changes or neuropharmacy. The picture I've chosen here is of a child with autism, and we know that there are kids on the spectrum respond really well to heaviness, something heavy on them, or hugs. Of course, there's that Temple Grandin, who came up with a lot of work on autism, the idea of having pressure on the skin. And there are now sort of hug blankets and hug vests that give that kind of sense of self, that sense of containment or pressure on the skin. So I want to move the conversation now onto therapeutic touch, because it's where we are. And as I said before, in a sense for me, what touch does is it introduces ourself to ourselves. It reinforces our sense of self. But I want to think of touch really as a neural input, to stop thinking about it, or perhaps pause thinking about it as soft tissue techniques and HVTs, but for a sense, just think about, what am I trying to achieve on that nervous system? What kind of inputs, what kind of landscape am I trying to achieve? Because for me, when someone comes into me with dysfunctional pain, effectively I'm playing with that, giving it back to their nervous system and saying, okay, now you deal with it. We've changed it, and now it's for your body to kind of integrate that. So touch is peripheral. The soft touch, this is a laminae sort of section of the spinal cord. And when we look at the spinal cord, it's divided into these different laminae. We talked a little bit before about the substantia gelatinosa. You can see it in yellow here. And that's an area that when the child falls over and the mom rubs the knee, you see that light up. So we know that there's this Melzack and Wall pain gate theory all around this substantia gelatinosa. But each of these different spinal laminae has a kind of different role in terms of relaying touch back to the nervous system, back to the central cortex. But what's interesting is that it's also at the level of the spinal cord. And a lot of research now into trigger points is looking at spinal reflexes, especially with needling techniques and other techniques. So we're going to look at that. So soft touch, or perhaps even cranial work, comes through lamina 3. These laminae are sort of slightly outside of the edge of the spinal cord. Lamina 5 is where soft tissue, which is the afferent CT fibers that we talked about before, up to the limbic system and the neuropharmacy. Trigger points tend to be around lamina 6, and lamina 6 is a slightly more stronger touch. So at any one time, when we're introducing touch to someone, we're having an effect on their spinal cord, which is relaying that nociceptive drive up to the nervous system. So touch is peripheral through the spinal cord, but it's also central, of course, as we said before. And one of the great ideas that I remember from college, I'm sure you all do, is this idea of this Penfield's homunculus. The idea of that actually the way our nervous system represents parts of our body is very different to the way we see each other. So in terms of sense of self, there are far more receptors in the hands and fingers and the lips than there are in the shoulder. So when things go wrong with certain areas of the body, the nociceptive drive is so much greater to get things done. And of course, there's a sensory and a motor map for these things as well. So we know that once touch comes up through the sort of nervous system, through the spinal cord, through the limbic, through the amygdala and hippocampus, it then goes into the M1 and the S1, the sensory and motor cortex. And these are the prefrontal sort of lobes, and these are the sort of central parts of the brain itself. So in terms of somatosensory cortex, it's the postcentral gyrus, just here in the brain, takes the information from the spinal cord through the brainstem, through the thalamus, and it relays it to the brain itself, and it receives this tactile information from the body for integrating touch, temperature, pain, and spatial awareness. So the brain is where the integration goes and where the decisions are made. And what happens is the inputs come in from the periphery and from the spinal cord, and then the brain makes the decisions. That it's the orchestrator and the sort of executive decision maker, the CEO. and then it will change some of the outputs. And for me, what's interesting is using touch creatively, especially painful, therapeutic pain, to modify those outputs. So what do I mean by that? Well, I think that really we have to look at when things go wrong in order to sort of explore what I think is happening in terms of what we're doing with therapy. So the question is, what happens when the body's in pain? I do remember very much when I was doing embryology at college, thinking that everything is the nervous system. When you look at the way the brain unfurls, the spinal sort of dermomyosomatons unfurl, everything seems to be driven by the nervous system. So the brain and the body really are one, and this is just the most beautiful dissection here, looking at the way the brain and the nervous system are connected. Of course, there were some creatures, some dinosaurs that had two brains because they were so large. They had a lower brain and an upper brain. So I just think it's a beautiful image to think about. So what happens when the body's in pain? Well, pain is really why our patients come to us, generally speaking. So pain is a hugely motivating sensation. It's a key motivator. It's the reason why we're able to, why we work, where we get our patients from. Pain itself has incredible array of functions, but if we just focus it down on what I want to think about now, what the nervous system tends to do, in my opinion, around pain is it does several things at the same time. First of all, it tries to protect us. How does it protect us? It protects us by shutting down. So there's this kind of shutdown. It also tries to adapt. So while, let's take, for example, the shoulder, frozen shoulder, it shuts things down and it adapts. How does it adapt? Well, I can no longer use my deltoid in the same way, so I'm going to use my supraspinatus. So it will change how we start to, it will adapt. So it's protecting us, and then it has to adapt. And finally, it has to make some really big executive decisions. And the longer pain is there, the deeper these reflexes start to go. And we know about, we talked some in the lecture last time about central and peripheral sensitization, the idea that once things have been in the body, pain has been there for more than a few months, we get profound changes all the way up and down the 5 to 7 levels of the spinal cord above or below the nociceptive drive. Now, like I said, really, when things go wrong, I think that tends to, like everything in life, when things go wrong, it tends to sort of teach us the bigger lessons. And what we're going to look at now is another fascinating area of touch called phantom limb pain. So, phantom limb, it turns out, is a sensory mismatch. What does that mean? We're born with 4 limbs wired into our nervous system. So our brain has maps of these 4 limbs. If one of those limbs is cut away or blown off in a landmine, what happens is we still have the map of 4 limbs, but we're not getting the feedback, the sensory input from one of those limbs. And what does the brain do? It invents feedback as a phantom. In fact, if a leg is blown off in a landmine, the pain of that explosion is felt constantly. That's what the patient feels. They feel the explosion going off endlessly in their limb. Or if it's been cut off in a machine accident, they feel the blade of the machine constantly because that was the last input that their nervous system got. And what phantom limb pain is a mismatch between the sensation that's coming back and the maps that are wired into our brain. Relatively common, up to sort of 80% of people that lose a limb will get a phantom. I love this image. This image here is the homunculus that we talked about before. You can see the way, the sensory homunculus, how the relative numbers of sensory organs determine really how our sense of self is. Of course, the way we see each other is not the way the nervous system sees us. What I want you to note very much here, though, is how the fingers and the hands are next to the, in fact, the cheek is next to the thumb. In terms of the homunculus, the cheek and the thumb are next to each other. The hand and the cheek are next to each other in terms of their sensory representation. So phantom limb, relatively common, affecting up to 80% of people. And as we said, the amputees or the people that have lost they experience a sensation in that limb. That's hence the word phantom. So even though it's not there, they're experiencing pain or discomfort. Now, there are actually a whole range of phantoms that can happen. There can be phantom nipples after people have had breast mastectomy. There can be phantom rings. People still feel their wedding ring on their hand. So, like I said, it's when we start studying when things go wrong that it kind of gives us a sense of the expansiveness of what the nervous system is trying to achieve. And, like I've said here, the cheek and the hand and the penis and the foot are mapped next to each other. Now, why is that important? Because when we look at sensory mismatch, we start to get some really curious things that happen. The way phantom limbs are described are often as burning or cramping, crushing, lancinating, that's very sharp pain. There can also be phantom paralysis, so people can feel their phantom limb paralyzed. There's this idea that they have no voluntary control over their phantom, and they feel that their phantom is somehow set in stone. They can't somehow access it. So the phantom itself has a whole set of discrete kind of sensations within it. Okay, sorry, I did something funny with that. Yeah, very good. Okay, so phantoms and touch. I don't know if you can see that image. It's very hard to find an image of a penis and a foot, so that's the best I could do. So what they found was that there was a doctor called Ramachandran that found that if he stroked patients' cheeks in a certain area, they would feel the phantom hand. And there were also patients that would come to him. He was a neurosurgeon, a neurobiologist, and they found that sometimes they would have sex and they would feel that when the penis was touched, they would feel their phantom foot. So he thought this is very, very strange. Why could it be? And the answer is that actually there's, I'm going to go back previously. The answer is that the way the maps are represented in the homunculus is that the foot and the penis are next to each other on the map for the homunculus, and the hand and the cheek are next to each other. And what happens is over time, you get an apoptosis of the neurons that are coming back from the limb because there's no longer sensation coming from that limb. The brain, having very important real estate, will start to destroy the neurons start to go through apoptosis, they die, and other neurons from other regions like the cheek and the penis will start to encroach and grow into that area where with that effectively that dead zone. So over time, what's happening is that there's a sensory mismatch. This is this idea of neuroplasticity, this idea that the nervous system isn't so much fixed, that there's a kind of plasticity that's going on. And I think this is something that we're playing with therapeutic touch as well. All sounds a bit mad, really, but there we are. So I want to carry on now to the other thing that's this other state of the body in type of paralysis, if you like, which is the frozen shoulder. Now, I've seen a couple of thousand frozen shoulders now, and the thing about a frozen shoulder is that it very much is a holding pattern. It's a holding pattern of the nervous system. And what do I mean by a holding pattern? Well, we talked before about this, the the nervous system shutting down around an injury. And you don't see that any more distinctly than in a frozen shoulder, where the long-headed bicep is very inflamed and the body tends to sort of shut off. I call it a holding pattern because it's almost like the nervous system is trying to protect us, but it's not entirely helpful. So there is Syriac's talked about some default positions of the nervous system. When someone's hemiplegic, when they've had a stroke, there's a kind of decerebration. And if we look at, that's not tremendously dissimilar to a frozen shoulder. Elevated, internally rotated, and flexed. Tight flexors, weak extensors. So it's kind of like a default position of the nervous system around, that's decerebration. But of course, what do we do with the body when we break the shoulder, when we have a dislocation of the shoulder? We put it into the brace position. So even orthopedically, we're tending to do that position, which effectively is what a frozen shoulder is. But the frozen shoulder, we're not putting it in a brace. The body is bracing itself. And how is it doing that? It's stimulating specific muscles to be tight in this kind of pattern, this switch off. So I call it a holding pattern because I think that that's very useful. And of course, when I talk about the frozen shoulder, I mean everything. Because when you look at a disc, for example, now, we see a holding pattern. I see the lumbar rectus spinae multifidus and the gluteus medius muscle, very much part of that holding pattern. When I see a hip, I look at the adductors. So actually, I think there are profound holding patterns of the nervous system around injury. And the idea that we're going to develop now is how using touch, therapeutic touch and painful touch, to change some of those algorithms. So pain changes the sensory feedback, or lack of a limb or pain. We get this primitive set of responses, these holding patterns, this altered somatosensory response. In the frozen shoulder, they call it the capsular pattern. That changes the spinal cord and the cortex, and that takes us in a kind of vicious cycle, in a kind of pyramid of change. So the nervous system then is forced to do something different. And this part, the bit behind, this was the sensory cortex, and here's the motor part, the M1 part. Has to do different things. It has to initiate motor movement, so it starts to use subscapularis in a different way for the frozen shoulder, infraspinatus in a different way. Again, very much to do with homunculus. It's connected to it has its own motor maps for the body, and again, they're not equally represented. But what's interesting with the motor maps is as we start to repeat activities, we start to reinforce those maps, which is also interesting in terms of with the frozen shoulder technique. I don't give exercises, but when we treat it, the power and strength come back spontaneously because there's a profound yearning of the motor system to restore itself to homeostasis, or however we say it nowadays. And again, as you decrease it, the use, we get this disuse. So aging. This kind of makes me think of yoga a little bit, because I really like yoga. And I think that yoga is the kind of vocabulary, if you like, of the nervous system. By taking the body into these different positions, you're expanding that vocabulary of the nervous system. Your sport in general, you're changing those maps, you're reinforcing them, and by putting the nervous system in these different places, it expands our sense of self. And of course, as we age and as we don't exercise and as we do less, we're going in the other direction. So in terms of the shoulder, we get this change in agonist, antagonist, and fixator, very much. So with a frozen shoulder, we talked about this pattern. The muscle that does that, of course, is subscapularis, the internal rotator. And that means that you're getting a disuse of infraspinatus, which wants to do that. But in fact, it's got a huge trigger point in there because it can't do what it wants to do. And then we get this change in the whole pattern. So in fact, the bicep pairs off with teres minor and the tricep with pec minor. This is part of my frozen shoulder work, which if you're interested, we can talk about another time. But it's not just humans, is it? Because what does when we see an animal in pain, it very much, a picture says 1,000 words. It's exactly the same thing. If we look at this dog, this forelimb, when it's injured, its forelimb. What does it do? It goes into the holding pattern. The nervous system is primal. These are primal body instincts. And again, just looking at the fetlock problem here with the horse, what's it going to do? It's going to flex its forelimb and it's going to raise it in the air and slightly internally rotate it. So these are primal reflexes. And the idea is that the nociceptive drive that inputs to the nervous system is going to be different in the map to the four limbs. So coming back to the phantom and looking at frozen shoulders together, what we're saying is that there's an expectation of where the body should be, but the motor and sensory systems are not in sync with each other. There's a mismatch. And how we're going to connect that mismatch together is what we do in therapy. So putting it all together, sort of trying to blend it all together. What we're really trying to say, what I'm trying to say is that the language of touch has a vocabulary. And what is that vocabulary? That vocabulary is this using the sense of touch therapeutically, this landscape of touch, to connect the self back to the self. And I'm going to talk about how I do it shortly with frozen shoulders. But we also talk about this idea of pre-verbal communication, how touch is so much more than just the superficial notion of touch, that it has this, I can be in a different country and I can touch someone's pain and I don't need to say a word because they totally understand that I've found the right bit. And so there's something about this kind of therapeutic pain. We talk about the emotional, the psycho, and of course we can't ignore the emotional. I said before, we're going to talk about the mechanical here. And I don't mean to belittle in any way the emotional and the psychotherapeutic effect of touch. In fact, I'm sure many of us use it deliberately as well, because, I think many of you understand what I'm saying. It's not just about the mechanics of touch. Over time, when you start to use touch subtly, you start to realize that there is a psychological body whispering, a kind of psychology to touch as well. And certainly with my psychotherapeutic friends that are art therapists and movement therapists, they all agree that touch is part of their work as well. So touch is our vocabulary, and then the question is, how do we combine our vocabulary? Sorry, my foot's got a bit numb. Hello, this sensory mismatch. How are we going to blend that together? And what I'm going to do is this. I'm going to take you back to what I said earlier, which is this idea that actually, of smoked salmon, that what we're doing is we are using touch to stimulate an algorithm effectively. Like I said, what is smoked salmon? It's an algorithm of bitter, salty, sweet, and the olfactory together. And I think that if we can, there are certain algorithms of how we combine a superficial, painful, deep touch, flexor, antagonist, agonist together that have a profound, very profound therapeutic effect. But it's this combination of using the sort of the landscape of touch. And like I said, it can be superficial, it can be deep, it can be pleasant, it can be sensual, as we said before. And I think the next stage we're going to look at is some really elegant experiments that have been done, not just by me, obviously, but we're going to look at something what I think is truly fascinating. So we look at the mirrored box experiment. I'm sure some of you have heard about that. By Ramachandran invented it. And then we're going to talk about touch as an input as well. So, Dr. Ramachandran, as I said before, he was a guy that people would report to and say that they would feel their phantom limb during sex, their phantom foot, and that he'd stroke their cheek and they would feel sensations in their hand. And he did this really simple but amazing experiment where he would take a mirrored box and he would get people to put their good limb in one side of the mirrored box and to look at the mirror, use their eyes to really focus on the mirror and really see the mirror image of their phantom, of their limb that was missing. Easier with the hand, of course. And he would get them to manipulate objects, oranges, lemons, and squeeze things. And what he found was that a hugely significant number of people, while they were looking at the mirror image, would start to feel the phantom limb go away, the phantom limb pain go away. In fact, it was quite profound. If you read his book, Phantoms in the Mind, he talks about incredibly profound, and some of these effects were longer lasting. They weren't just while people were using the mirror box, they were long lasting, and they went well on after that. And in fact, mirror boxes are used routinely now for people with phantoms, phantom limb pain. And I remember reading some of the incredible stories of people that felt their limb just start to, the kind of gnarly limb would unfold and would start to come back, and they would start to feel the kind of normal sensations again. And what he said, and I really just think this is the crux of what I'm trying to say here, was just so profound that I just want you to think about it with me for a second, which is that we talked about sensory mismatch. And what he said was this: he said that he was superimposing the visual image of the phantom. And by using the visual stimulus of the real arm, they superimposed using the optic complex, the sense of eyesight, was reinforcing the lack of sensation coming from that phantom. So let me say that again. We've got the maps of four limbs in the nervous system. We're not getting the feedback because that arm is missing, or the foot. But by using the eyes, a different modality, a different sensory modality, you are able to change the output of the nervous system. So your sense is that you're constructing a new image of self using the available input. So instead of using the sensation as the input because it's no longer there, you're using the optic complex, the visual complex, to reinforce a sense of self. So I'm going to pause for a second and think about that. It's incredibly profound. And why? Because I think hopefully it's quite exciting. Because what are we doing as therapists? We're going to talk about that now. What he would feel was that patients felt their withered phantom limbs coming back to life, unwinding, unfurling. Their pain was either diminished or completely stopped for a hugely significant number of people. So the idea here is that we're using a different modality to change the sense of self. Okay. So let's kind of putting it all together. So where are these maps, and what kind of maps do we see? Well, I live in trigger points, which is a whole world of maps. Trigger points are all about maps. In fact, the maps in trigger points were started, we said last time, by some of the doctors who would inject saline into trigger points or anesthetics, and they would get people to map out where they felt the sensations with the trigger points. And large numbers of people would feel them in different places. Generally, they were felt in the same areas, which is where you see the darker red. But some people felt them in other areas where you see the sort of lighter patches. So the trigger points are all about maps, and the mind is all about maps, really, or certainly the mechanical part of the mind. Cool. So let's think of touch as a neural input. Like we said, there's a kind of idea of hardwiring and soft wiring. So we've got the limbs hardwired into our nervous system. We, oh, hello, sweet, who's that? Sweet. Gorgeous. Well, we have a baby here as a demonstration. As the baby crawls and it integrates its nervous system, as it starts to develop, this reinforces this map of these four limbs. In fact, I'm sure many of you remember that amazing study of a kitten that was never allowed to walk, wasn't allowed locomotion. It was carried around the lab by the scientists and stroked and loved, was never allowed to walk, and its eyesight didn't develop properly, and it wasn't able to balance properly. So all of these locomotion integrates these maps. So we have the kind of hardwired map of the four limbs, but we also have the soft one, this feedback that's coming back the whole time. And this is where the phantom limb and the mirror box comes into it, where you're replacing the lost input from neural input from the limb using the visual cortex. So like I said before, by using the eyes as the primary sensory feedback, the brain can override the lack of feedback and reinforce its sensory and thus motor maps, enabling a new circuit to be connected. So for me, in many ways, that's what we're doing as therapists. When we see someone that's coming in pain, they're in a kind of holding pattern, in a dysfunction. And rather than use the eyes to override it, we're using therapeutic pain or touch algorithms to change the sense of self, to allow the nervous system to reinforce itself using painful sensations, especially with trigger point sensations or other sensations, to unblock that holding pattern. So much like the phantom is there because of the change in feedback, once the body's in a kind of shutdown, a holding protective pattern around injury, around pain, we're using the pain pathways to try to change and reinforce the sense of self. So we're using therapeutic touch to change the maps of self, very much with the trigger points. And we're using therapeutic touch to change the sense of self with painful touch as a huge motivator. Why? Because we said before, why do patients come to us? Because they're in pain. Pain is a huge motivator for the nervous system. So using pain therapeutically, or deep touch, or therapeutic pain, and I'm talking about that sort of pain again, just to be clear, I'm not talking about deliberately hurting someone, God forbid. I'm talking about that pain when you go to a massage and that massage therapist is a millimeter away from that bit and you just think, oh, please. When you hit those therapeutic trigger points, if you like, for want of a better word, even though they're painful initially, if you hold them, the patient can let go into them, and then this kind of magic can ensue, this connection to self, this change in the nervous system. If you hold them for long enough, the whole, and you know this yourself if you work with these concepts, is that the whole body can sort of let go and reintegrate itself. So in many ways, pain is a gift. Of course, it's also a curse. I'm not trying to be trite about it, because of course a lot of people live in with the curse of pain. But why do I think of it as a gift? Because, oh dear, there's questions, I'm sure. Sorry. Why? Let me explain what I mean by that. Is that pain tells us where the problem is, so it helps us locate the problem. It tells us what the problem is. You know yourself that a ligamentous pain is different to a muscular, is different to a disc. You know, over the years, as you come to work with these different types of pain that people come in with, you very much learn quickly what sort of pain belongs to what organ, if you like, or what structure. So the pain tells us where the problem is, and it tells us what the problem is. Now, is it worse in the morning? You know, is it arthritic? Is it worse towards the end of the day? Is it muscular? So all these questions in our case history are to allow us to, the pain guides us to what's wrong. And pain actually, if we think about it like that, is its own language. It's its own language of the nervous system. It's the pre-verbal language that allows us to sense ourselves. It's the feedback mechanism. So by using therapeutic pain, by using painful touch or therapeutic touch in a deliberate way, we can connect back to self in the same way that we're using the eyes over the visual cortex to override the lack of reflexing with a phantom. We're using the therapeutic touch to change that mismatch between the S1 and M1, the shutdown patterns around injury, the protective shutdowns, And we're using the pain to break that cycle, and we're using it to change that sense of self or shift that holding pattern. Deliberately, for example, in the frozen shoulder, the main problem is subscapularis, but of course, if someone's really stuck, you can't get your fingers in the armpit. So part of the technique that I use, that I've developed, is we hold a trigger point in the infraspinatus, which is what I call a super trigger point, where it's always switched on in people with certain shoulder injuries. And it's exquisitely painful. When you put your fingers on it, even if you touch it gently, people can't even bear it. But we ask them to sink into it and hold into it. And what happens is, after a while, as they allow their shoulder blade, their scapula to fall, and you're on that trigger point, you find that the subscapularis starts to open up. So we're using painful touch on the infraspinatus to change the neurology of subscapularis, to allow it to relax. And that's because they're agonists and antagonists. So what we find, what's fascinating, for example, with the frozen shoulder, is we can treat subscapularis pain using painful touch of the infraspinatus. And it's almost like the patient can't even bear at the beginning to drop into that painful trigger point. But as you hold it and they drop more and more and more and they let go, all of a sudden you start seeing this external rotation start to just melt and come back. It's almost magical to see. You can't believe what you're seeing, because you're not treating subscapularis, you're treating infraspinatus. So this is what I'm talking about in terms of using therapeutic pain in algorithms, in terms of how we're affecting the nervous system. So treating pain with painful touch. We talked about taboos at the beginning, and I hope I've made it clear again and again that I'm not advocating pain for the sake of pain. That's not what this is about. This is using deliberate trigger point pain or painful therapeutic pain in a dignified and in a mature algorithm that allows you to change the input to the nervous system, the nociceptive drive to the nervous system. So I should pause for a second and plug the most amazing new piece of software, if you haven't seen it, Trigger Points 3D. And it's basically, all joking aside, this software I've developed to demonstrate how trigger point maps look. So the idea here, for example, latissimus dorsi, this is the upper trigger point of the latissimus dorsi. If someone's coming in with painful map, so in the inside of the arms, periscapular pain in the tricep, sometimes that map may be because there's a trigger point in the latissimus dorsi. So the idea with the software allows you to look in 3D as well, and if you don't know where the maps are, to look at the person in that way as well. But again, trigger point maps are very much maps about pain and about the nervous system, very much to do with this notion of using pain to treat pain and therapeutic pain. Trigger points are exquisitely painful, exquisitely painful. When you press on them, there's a wince or a twitch or a jump sign if the patient wants to jump away. But as you hold them, as you sort of sustain them, the body just gradually lets go, and after a few seconds to minutes, the whole nervous system just changes that and lets go. It's kind of magic. Trigger points, I believe, are wired into the body deliberately to switch things off. So we talked about a holding pattern before, and I think that there's what I call trigger points on demand, which is like TV or on demand. It's like the nervous system wants to shut something off quickly. So what does it do? It sort of stimulates what are called polymodal receptors, which are receptors that can effectively morph into trigger points under the right circumstances. And the purpose of a trigger point is to make something weak, to make it not function well. Now, it's a bit counterintuitive, you think, but actually, if you think, if the body wants to go into a holding pattern, wants to switch off around an injury, wants us to allow the body, the wisdom of the body is to allow it to rest, or to while it's trying to kind of integrate and work out what's going on. Trigger points are very much deliberately put in there by the nervous system themselves. But once a trigger point develops, they do warp sensory perception. What do I mean by that? Well, they're going to change the homunculus. They're going to change the therapy, the map of the nervous system, because you're starting to get the nociceptive drive from the trigger point really firing. So it's going to start changing those pen-filled homunculus maps, the sensory nociceptive drive, the drive up through the spinal cord, through the thalamus, through the hypothalamus, through the limbic system. So all of these things are going to be affected by the trigger points that are there. And as I said before, not only are they exquisitely tender, localized, nodular, kind of discrete, painful, therapeutic areas, but they also have very profound effects on the autonomic nervous system. And that is pretty exciting for me. So this is a summary of some of the kind of dysautonomic effects that we know about. For example, hypersalivation, epiphoria, which is increased tear flow, conjunctivitis, that's sternocleidomastoid, both of those actually. Ptosis, you can get with trigger points, blurring of vision, diplopia, increased nasal secretion, goosebumps on the flesh around where the trigger points are. And also, there's a type of parasympathetic. These are all sympathetic problems that can happen, dysautonomic with the autonomic nervous system. But there are also some parasympathetic ones. For those of you that are familiar, some of you have looked at my work with the frozen shoulder. We know that when we're treating the long-headed bicep, for example, in a frozen shoulder, we start to get borborygmi sounds in the stomach. And of course, you know yourself, when you're treating someone and you're holding something, you start to get that stomach sound. And you know, intuitively, we know that it means that something's changing. There's some kind of autonomic drive that's going on that's changing. So therapeutic, so we've got touch, we've got therapeutic touch, and we've got painful touch, trigger point touch. So how do we integrate touch techniques using this therapeutic touch? How do they work in terms of changing our sense of self? Well, we talked before about the mirrored box, and I would like to propose that some of the ways this therapeutic touch works, and again, or trigger point or painful touch, deliberate touch works, is by algorithms. And again, this is ideas that have come up for me from treating frozen shoulders. So in a frozen shoulder, we get this change. The tricep and bicep alter, the subscapularis and pec minor alter. So the functional relationships of the nervous system change profoundly. Instead of getting a bicep and tricep agonist, antagonist, you get the subscapularis and bicep, or pec minor and bicep. You get teres minor and tricep. So these kind of functional antagonistic relationships are plastic. They're not in one place anymore. So when we want to receive a signal for our cell phone, when we want to find out where we are on a map, we use something called triangulation. And I think very much that's the way I work, specifically when I look at the idea of therapeutic touch, is to triangulate things. What do I mean by that? In order for a GPS, for a satellite phone to know where it is, it needs 3 points. Once it has those 3 points, it can know where it is. And I think the nervous system is the same. So what are these 3 points? They're an agonist, an antagonist, and a super trigger point. I call them super trigger points, or fixator, some kind of other part, a third part, if you like, of that agonist-antagonist relationship. So I'm going to treat, if someone comes in with a tricep problem, I'm going to look at the bicep. I'm also going to look at the teres minor, because for me, that is this kind of triangulation. So when we're using deliberate touch, it's almost like there are recipes of touch that we're combining this kind of profile. Like I said, smoked salmon, we're using some of this and some of this and some of this in a very deliberate way to change the relationship of that holding pattern of the nervous system, that shutdown pattern around an injury, to drive it back to homeostasis, to drive it back to release it, to remind it of its sense of self. So this idea of triangulation, we're always going to use 3 points. Often treating the bit that the person comes in with last, we use that at the end, because often that's, even though that's the primary lesion, if you like, it's the way the body's changed and shut down around that we're going to treat first, and then we can come to that primary lesion. I'm sure that's a concept that I know that we studied at the BSO, that sort of treat the bit that hurts right at the end. But this is perhaps why, because of this idea of triangulation. So, to conclude, I'm sure you're very happy about that. Touch is powerful, pre-verbal, primal, and profound. The nervous system and brain will adjust to pain and injury in holding patterns. And the brain itself works in maps. We have limbs, 4-limbed map that are reinforced by our sense of self, our drive all the time, proprioceptively, from touch, from our sense of spatial awareness. These maps are constantly being reinforced. And the touch, I didn't put it here, that when things go wrong, it's an opportunity to study those maps and how the relationships come. And that touch directly affects the brain. It affects the brain from the level of the spinal cord, all the way through the limbic system, all the way to the neuropharmacy of the cortex itself. And by modifying and modulating touch inputs, a topography, a landscape of touch, we can have a profound effect on motor output. So when we treat the infraspinatus with the trigger point, some of the frozen shoulder, we're having a profound effect on the subscapularis. We're profoundly affecting the motor output of the cortex, of the M1 part of the cortex. We also said that trigger points, which are part of the kind of whole painful touch notion, they warp sensory perception. So when they're there, they have a changing of those maps again, and they have their own kind of sub-maps, if you want. And we also talked about the idea of therapeutic touch, or painful therapeutic touch, to be used deliberately. Or I put desperately, that was wrong. That should be deliberately in algorithms, desperately perhaps for some, in algorithms. So the idea of using touch to change our sense of self, using sensory input to change motor output. And that, I believe, is the end of my workshop. So a lot of stuff to take on board, and I hope I explained it all, the ramblings of madness, well. These things they do mean a lot to me, and these are things that I sort of think about in my spare time. Certainly, it's such a privilege to touch people, as you all know, and it's such that actually I think it's beholden upon us always to kind of think about what we're doing and try and understand it a little better. And I hope that this has given you another insight into the role of touch. So that is that. Okay, there we go. It's the first time I've given it sort of this workshop. So
oh no, that was brilliant. Thank you, Simeon. It was really good. It was nice self-reflection as well of what we do and how powerful what we do is.
Everyone's left. I think they've all left or gone to sleep.
No, not at all. Can you hear me all right? Okay, cool. So Catherine has posted a couple of questions, but I'd quite like to speak to you and ask those questions. So I'm going to turn Catherine's microphone on. Everybody, so if you'd like to ask a question, put it in the chat box or the Q&A box, and I'm going to keep an eye on it and read it through. Equally, if you'd like to have your microphone switched on, then just let me know. Okay, Catherine, this is saying that you've got an old version of Zoom, so I'm going to promote you to a panelist, so your camera will come on as well, but you can turn the camera off if you so wish. So we'll just give it a few seconds while Catherine joins us.
Okay.
But Rob had said, thank you, very interesting, but he has to go. I know, but we're going to carry on recording, Rob.
Which Rob?
There's Catherine. Hi, Catherine.
Which Rob was that?
Robert David.
Is that working?
There you go, it's working.
Came back.
That's because I had
cool.
to change. I had to promote you to the panelist. Here you are. Welcome. Here's Simeon.
Nice one. Yeah, hi Simeon.
Hi.
Yeah, I had so many different bits in my head. I thought I could just speak to you, and I just want to say I think that was a really cool talk, and I really enjoyed it. And there's lots of I've been thinking a lot about these ideas too, and it's nice to hear some overlap, like this idea of I've even used that analogy of being a bit like a talk therapist with the body. I feel like that reflection we give back to people definitely is a big part of what we do. And I was one of those, I have to get out of this office and use my hands to do something. People, I love that.
Enough of computers. You just have to touch people, right? I know there's a drive towards that. There really is. And
it's also really nice in this sort of day of evidence-based medicine to have this kind of scientific formulation around what we're doing with touch, and that touch is pharmacy and touch is important, because a lot of as you said, at least over here in Canada, there's a push towards this no touch physio, and touch doesn't do anything, and let's just get some exercise. So I love that you're one of the few voices out there that's valuing and thinking about what we actually do with touch, because it's so I really like that. And then my question is, so first of all, I want to get your software, and you've given me a reason to start playing trigger points again, and rather than like throw that theory out. So I totally get what you're saying with painful or using nociceptive inputs to break patterns. But that I just have a big question mark around. So I totally get if people have a healthy nervous system, and this is an acute pain condition where they do a movement, they get a pain, it has this kind of pattern. This approach makes a lot of sense to me. But if they've got persistent pain, if they've got allodynia, if their systems are really sensitized, and you put in more pain input, I mean, I haven't tried it, but I haven't tried it a lot yet, because I tend to go the other way and use ease input. But when you apply this protocol to everyone.
What's fibromyalgia?
That was me, because I actually listened to your last lecture about frozen shoulder, and I have I know a person who is getting frozen shoulder that has a big history of fibromyalgia and has a math therapist. So we tried out your protocol, and I gave them the protocol, and they gave it but it had a positive effect initially, but then it got the usual pain drag.
The trick with that kind of, if you've got these high performance of those trigger points to fatigue, and that can be from 3 to 5 to 10 to 15 minutes. So sometimes I'm holding a trigger point still on that trigger point for 10 minutes and more, because it's almost like there are different theories. That one of my gurus is a guy called Bob Gerwin, who's head of pain medicine at Johns Hopkins and a neurologist, and he says that using trigger point needling techniques is incredibly valuable for fibromyalgia. Needling these trigger points, and needling is one of the most aggressive, if you like, sort of trigger point techniques in a way, because you're getting that twitch response, you're getting that nervous system, that local twitch response. So I think there is a place for using deeper pain to change the nervous system in people that have sensitization. However, it really has to be done sensitively, and it has to be done with a lot of thought, because the last thing you want to do is flare someone up. And in my experience, it's about holding that trigger point until it literally has to let go. But actually, in those cases that are that acute or that sensitized, you get incredibly profound positive effects. So it's a double-edged sword. If you're prepared to and you have to explain to someone what you're doing, and you have to have them as part of that relationship. You can't impose it on them, because then their nervous system will react. But if you talk to them about these deep kind of areas that just aren't letting go, and you hold and hold, and the trick is over time is that it's a dance. You feel the trigger point letting go a little bit, and then you think, oh no, I should let go now. It's not there, and then you have to let go a little bit, and then you go back in until you really feel that. And I can only say it for you as well, that when you have a massage, and I reflect it back on you, when someone is just a millimeter away from that pain, and you just think, oh please, move. You know what I'm talking about, right? Just if you move the millimeter to the left, that's exactly where it is. So I think what I'm talking about is there's this built-in system of, and this is where it comes into the monkeys and the apes, this therapeutic pain system, which goes through these CT afferent fibers to the limbic system and to the other part of the thalamus and to the other parts of the neuropharmacy, that if you get that right, you're going to have such a profound effect on fibromyalgia, because we know fibromyalgia is a central sensitization, is a cerebral thing as well. So if you can stimulate that neuropharmacy by using this that pathway, and I think that's why I found it exciting, the CT afferent pathway in the monkeys, which you should have that paper that he did, is that actually what that is this pain pleasure, some area of pain pleasure. Again, it's almost a taboo to talk about it. It sounds like people want to laugh, but I think you know what I mean, because it's what we do. It's our if we have to have an honest conversation about it, because it's there's truth there as well.
Yeah, although I'm going to have to go back and read up a bit, because my understanding is that so you talk about, if I went to get a massage, sure, I can feel these points and I want someone to poke them, but I have a relatively healthy nervous system. Really.
So there's a great deal on it.
It's different if when people have been, then those nervous system pathways modify, and that's why things like exercise therapy or physical activity is really good for people to create endorphins and activate. You know what I mean? When they don't have chronic pain, but if they do have chronic pain, the studies show they don't get that same neuropharmacological response.
Well, let me say another thing then, because I think this is really important. I think I now bring touch down to a very minimal set of inputs. I try and do as little as I can in the most effective way, because if you're doing lots of soft tissue and lots of deep work and lots of things, then the nervous system, especially if someone with sensitization, is overwhelmed. It's very easy to overwhelm that nervous system. If you're choosing a specific trigger point that you think is part of, rather than giving lots of a whole topography, a whole landscape of touch, which is very overwhelming, then I think it has a very different therapeutic outcome. So just for something for you to think about.
Yeah, that's really helpful. And also what you said about you might have to hold it for 15 minutes. The classic trigger point is like 10 seconds or a minute or 2 minutes.
Yeah,
so,
really. Something like
that totally makes sense what you're saying. And I think
about letting the patient let go into it as well. They have to sort of welcome it, because it's almost like you are the holding point, the still point for their nervous system to let go. And in order for someone that's that degree of sensitization, that degree of kind of overload, there's so much going on that to let them get to that point where they can let go, it takes time.
I just think I guess there's a part of this is that relationship you've built up, because I think my understanding is one of the differences between threat pain, which a lot of patients I see, they're so afraid now of if their pain is still hurting, more damage is happening, compared to pleasure pain. Pleasure pain is that you feel safe and you're with you trust that what's happening is therapeutic and not damage.
Yeah.
So, perhaps maybe not the very first time they come in, if they're sensitized, you
Agreed.
start pushing the pain button.
I think I agree with that. I do think though and like I said, part of this thought came about because I was unable to speak the language, and yet I was able to communicate with people because pain is its own universal language. When someone comes in with a rib 1 lesion, and you press it, and they just know. They just know, and they trust, and they switch off because touch does have its own kind of language. So there's just that thing to think about as well, pre-verbal.
Yeah, that's great. Thank you for giving me a chance to ask
Anytime.
other thoughts. So it's very cool. I appreciate what you've put together, and it's given me a lot of new ideas to add to my thoughts. So thank you.
Pleasure. Thanks.
Amazing. Thank you, Catherine. I'm just going to switch your camera off if that's okay. So see you later. Eleanor would like to ask Simeon, what to you is the difference between trigger point pressure on holding treatment and acupressure? Just philosophy or?
Yeah, well, so I have a cousin of mine that's a really amazing acupuncturist, and he talked to me about actually the original acupuncture used to use things called the I Chi or I Ching point, or ouch points. So there's a whole system of acupuncture on ouch points, which is painful points. I think it's important to define that the trigger points are discrete entities within tight bands of muscles which have a referred pain map, which is very discrete. So the one that I always think of is like quadratus lumborum, which is where someone's coming with hip pain or pain down the side and front of the thigh, or they have pain sitting to standing. And with acupuncture or acupressure, you might want to go along a meridian, for example, the gallbladder or the spleen meridian, and hold on those points there. Whereas with the trigger points, you will want to come into QL, and you'll want to hold on that QL trigger point. So I think it's more than a philosophy. I think it's, and one of the glorious things about trigger points, and we talked before about osteopathy and trigger points, the marriage made in heaven, is the fact that we're already doing these techniques anyway, and we know the anatomy. You know, it gives us such a huge advantage to know the anatomy. Because if I said QL to a doctor, they would think it's somewhere here. You know, they can't remember where it is at all. Whereas when I say QL to an osteopath, it means a whole different thing. So I think the answer is that possibly, like all things, the technique may be very similar, but the knowing where these trigger points are by understanding the maps is what it's all about. And actually, the more you understand the maps, the more you refine your knowledge of what these trigger point maps are, the more effective your therapeutic outcomes.
Amazing, thank you. Do we have any more questions we'd like to ask? A couple of comments. Tim has just said, very interesting, have to go, thanks Simeon. For sure, a big overlap with Head and Hilton's ideas relating to trigger point ideas, hence the viscerovagal connection too.
Agree, brilliant. And also the term Nueropharmacy, I love that term. When I read about
it's a great term.
Thought, brilliant, you know, brilliant. There's some brilliant things out there. And I just love that idea of monkeys and primates. You know, I'm just going to finish since people have left.
Yeah.
You know, I don't know, but I used to do a lot of work with George Michael, bless him. And I once was on tour with him, and he was asking me what I thought about the tour and all the different dynamics and the people. And I said to him, you know, it's like there are 144 people working for him on this one guy on this tour. I said to him, you know, it seems to me it's like a bunch of apes, and you're like the alpha male. And I said, and I am the groomer ape that soothes you by picking the fleas off. That's kind of how I see it. So he said to me that he went out that evening thinking he was a big monkey. And I think that what I meant by that is that you know, we are groomer apes. That is our role as an osteopath in a funny way. What does that mean? It means a lot, because when you start working with someone, part of the privilege is that you really do form a bond with them. You form a relationship in that touch, which is why it's dangerous, but which is why it's also incredible as well. Which is why we have to be deliberate and understand it. Sorry. Yeah.
No. I am listening. I'm responding to some messages, and it's so true. It's so healing in many ways as well, because at the end of the day, I'm thinking of my older patients who have absolutely no human interaction at times, apart from a cleaning lady. And so the therapy of touch just becomes something else to them, to be human again.
Yeah, and again, you're connecting them back to them, you see,
Yeah.
because so long in front of the TV, which is connecting them to nothing. It's so profound, really, and it's a shame. It's a shame that some physios are advocating no touch therapy, and there are. I mean,
Yeah, it's happening here in the NHS as well. Quite a few of my patients have had no touch physiotherapy. Lots of thank yous. Louisa, Simeon, that was amazing. It really starts to explain the therapeutic approach that I've adopted over the years as an osteopath, and starts to give a model to explain how treatment works. Thank you. Lots of thank yous have come in. We have kind of gone over here now, so a great thank you to everyone who has joined us. There's a couple of questions that have come up for you, from Catherine, about the software, so I'll ask you those in a second when we've stopped recording, or you can see them in the box, can't you? Treating patients often have a very profound reaction. They do. Patients often cry. Goodness, they do. Sorry, I missed the beginning. Andrew, don't worry, it's all being recorded, so you can catch up. And thank you, Sarah, for coming on. Thank you, Charlotte. And I will update Simeon's slide on the website so that you've got this version that is played today. But Simeon's, you said you worked hard on this, and he kept kind of changing every time you kind of adapted it and changed the flow, didn't you? It's all good. You covered everything.
yeah.
Brilliant. So in the chat box, if you're still with us, is the link to Simeon's Facebook page for trigger point therapy, so you can get more information about it there. The website's also there. Simeon's shared that. And his email I posted in there as well, which is just simeon@triggerpoint3d.com, I think, if I remember right. So if you have any more questions you'd like to chat to Simeon about the app or anything, you can message him via Facebook, you can email him. He's really approachable. He's also in our Facebook group page, actually. I forgot to say that. You're in the OsteoAl members page, so you can chat and tag him there directly.
Thank you for all the hard work that you put into organising.
You're so cute. I love it. Thank you.
Thanks,
Thank you. It's a good fun. It's a good project. Brilliant. Right, so I'm going to stop chatting. No, I'm not. I'm going to stop recording.